Hi, I'm Dr. Miller, FirstHealth of the Carolinas intensivist, and I appreciate the opportunity to speak with you guys today. There are several takeaways from this talk. Most importantly, as we look at sepsis, an acknowledgement of the diagnostic challenges that I think, frankly, require new approaches in 2025. The thought that a test called SeptiCyte RAPID may influence the initial consideration of sepsis, and also that that same test may provide some assurance to diagnosis and therapy for sepsis. And I will go through some of our local data preliminarily that demonstrate this. First Health of the Carolinas is a system of four hospitals that has 100, about 145,000 ED visits every year. Up to 5% of those ultimately have a sepsis alert prompted for patients. And as we all know, decisions have to be made quickly, not just for the sake of the patient in that moment, but because regulatory agencies demand that we pay attention and deliver both the correct diagnosis and proper treatment as quickly as possible. And in the case of sepsis, if we don't think it's sepsis, despite the alert, to look for alternate etiologies. So our dilemma as we confronted it was to recognize a high number of EMR-based alerts, medical record-based alerts, and how could we manage this volume while paying attention to both clinical diagnosis and stewardship of cultures. We ultimately had a series of questions that we focused on and honed it down to how can we inform antimicrobial stewardship following admission, including duration of antibiotics? And importantly, is there in fact a tool that could aid clinicians in ruling in or out sepsis? We know that there are an almost innumerable list of tools nowadays, from the omics, proteomics, metabolomics, et cetera, to putative biomarkers, to other tools that can be used and have been used, including procalcitonin, for example, to try to distinguish whether somebody has sepsis or non-infectious systemic inflammation. There is a more novel host response test that has been developed over the last several years and has been approved to investigate and help discriminate these two. So the test itself, SeptiCyte RAPID, and I will explain why it's called RAPID momentarily, really looks at the ratio of mRNA expression of two host response genes to the presence of infection. Importantly, this test provides values independent of disease severity or causative pathogen, and as I said, helps to differentiate sepsis from systemic inflammation. When it does so, it reports a probability score, and these then are allocated into four different interpretation bands. I mentioned the rapid piece of this, and in fact, the rapid is important for all of us, as we know at the front line, because getting actionable results quickly can modulate both the recognition of sepsis, the search for alternate etiologies, and the determination of how long perhaps to even give antibiotics if needed up front at all. It runs on a platform, as you can see here, that has about a 2-minute hands-on time. And then, as I previously noted, provides results across four different bands that range from a low risk of sepsis to a higher risk of sepsis. If you will, the ultimate decision in terms of how to interpret this test, like everything else, is often put together with clinical data. And so if you look in a clinical validation study performed with SeptiCyte RAPID, you see that used in that way, in combination with clinical data that we traditionally use, the area under the curve is about 0.85, which is uh, uh, frankly, in 2025, about as good as we have been able to get for any marker, certainly in the realm of sepsis. It is thought that, and demonstrated through this study, that there was high sensitivity, so that if you received a result in band one, the negative predictive value was zero 0.9, and that if you received a result in band four, that the positive predictive value was zero 0.8. As you can tell, of course, in between, you get more intermediate results. And it is, of course, then important in those cases to recognize an increasing likelihood of sepsis, but also the importance of looking at alternate etiologies if you have a band one and perhaps even a band two result. And we'll go through a case and look at that here in a moment. So this is an 82-year-old gentleman with coronary artery disease, diastolic dysfunction, prior TIAs, lung disease. You can read all the information there. And he came in with altered mentation and weakness for 3 days. He was hypertensive, tachycardic, had a lactate that initially was 3.5 and fell to 1.8 with gentle fluids. This was a gentleman, because of his history, who did not receive a 30 cc per kilogram bolus, but rather a somewhat smaller bolus. And he had no white count elevation, a little bit of elevation in his creatinine, and you can read other values there. We obtained, because of the possibility that he could have, for example, a urinary tract infection, a SeptiCyte result, and it fell in the band two realm, which, as you can see, as we decided to label in our system, the probability of sepsis is estimated around 22 to 24% in such patients. This patient went on to go ahead and get vancomycin and piperacillin tazobactam because the risk of infection. He seized a couple of times in the emergency department and then became progressively hypoxic. And for that reason, ultimately had bronchoscopy with secretion removal that resulted in improvement in that oxygenation. After admission to the ICU in this case, he had PCR-based studies and routine cultures from bronchoscopy, as well as a slew of other things that ultimately were negative. And so we terminated the course of antibiotics at 72 hours or just before then. And the relevance of this case is perhaps obvious, I hope, but it is to demonstrate that the test pointed us in the direction of an alternate etiology of a simple aspiration as opposed to a true infection. And for that reason, it allowed us to stop antibiotics sooner than perhaps we might have otherwise. This one case is but one of over 5,000 patients since December 2023 at our main campus that we have employed SeptiCyte RAPID in the evaluation of sepsis through our initial sepsis bundle in the emergency department. Among the first 735 patients suspected of sepsis, only, interestingly, and perhaps not surprisingly to those of us who do look at these data closely in our institution, only 27% were ultimately admitted with sepsis. Now, of course, not all of those were also discharged with sepsis. And this came not just, in other words, from a perspective that we were seeing lots of patients being triggered for sepsis through the medical record, but also a concern that we perhaps had a desire, an interest, a perspective that allowed us to overcall sepsis some within our organization. And so we had sought such a tool as SeptiCyte Rapid for the purpose of determining if that was the case and if we could do something about it. And so these data provided some of the first inklings of that opportunity. As we continued to look at this, as among the remaining 538 patients, that is to say, those who were not admitted with sepsis, 40% of them had results that fell in the band one realm, and another 40% roughly were in band two. which means that about 80% of those we could pretty satisfactorily either rule out sepsis or make sure we sought an alternate diagnosis. And then again, as these are preliminary data, we don't have all the pieces of the puzzle to put together, but we do know that among 125 patients admitted to the ICU, 64% who were discharged with a sepsis diagnosis had a band 3 or 4 result. And so I think it's important to recognize that the test in this case performed pretty much as we would have expected, that if you had sepsis at discharge, you were very likely to have had a high SeptiCyte RAPID band score. Now, of course, we recognize that all of this is in the context of the future of precision medicine and sepsis. And while there are innumerable articles, as I mentioned previously, and studies looking at different approaches, it is thought that perhaps we need to combine a really good diagnostic tool with a really good pathogen detection process. And the science is perhaps a little out front historically in the detection of organisms. And so I think that SeptiCyte Rapid represents an opportunity to push forward the diagnostic process and really help tip the scale in the presence of a concern, a patient presenting immediately to the emergency room for whom you don't know the absolute truth immediately, in helping to distinguish whether they in fact have sepsis or perhaps not. So I hope through this presentation, I've had the opportunity to demonstrate and to acknowledge diagnostic challenges with sepsis, and then to show how, at least for us, and I think through published data for others, the SeptiCyte Rapid is able to influence the initial consideration of sepsis. And then finally, to give at least some very preliminary data that demonstrate SeptiCyte Rapid is helping provide some assurance when sepsis is not present, and when an alternate etiology cannot be found and sepsis is possible, that we are mindful of that with antimicrobial stewardship. And then, of course, when sepsis is in fact very more clearly present, that it allows us the opportunity to provide reassurance to that diagnosis. With that, I will accept any questions.